So it's my pleasure to present a couple of, not slides, this couple of video. First of all, I will present in-hospital pathway, our protocol for in-hospital pathway of the patient. And after that, we will discuss. And after that, I have another two videos for the present.
Dear colleagues and friends, today we would like to present the stroke patient pathway and the treatment algorithm followed in our hospital. After a call to the emergency medical services, the patient is transported by emergency medical services and immediately received by our colleagues in the emergency department. A neurological examination is performed, followed by a non-contrast CT scan and a contrast-enhanced CT scan. It is important to note that every patient undergoing intravenous thrombolysis receives a red stamp on their medical documents, which prioritizes their treatment. If thrombolysis is successful, the patient is transferred to the intensive neurological care unit for monitoring and recovery. However, if thrombolysis is ineffective or contraindicated, we proceed with mechanical thrombectomy. We typically start with an 8 French access using a decile, followed by an 8 French guiding catheter and a 6 French distal access catheter. Our first line approach is always thrombus aspiration, as it is the fastest and most cost-effective method for clot removal. If aspiration fails, we proceed with mechanical thrombectomy using a stent retriever. In the first pass, the guide wire and microcatheter navigate through the clot. We then retrieve the distal catheter, microcatheter, and stent retriever together, successfully removing part of the thrombus. Successful thrombus removal. The patient is admitted to the neurological intensive care unit and placed under active monitoring. A follow-up CT scan is performed at the 24th hour. Our hospital has a dedicated neurological unit with 12 beds, equipped with intubation capabilities and other critical care resources, ensuring comprehensive post-stroke recovery and patient support.
In hospital pathway of the patient with the stroke.
Makes it so much more visible, seeing the images and seeing the whole pathway.
Yes.
So absolutely. Can you just walk us through the devices that you were using?
For the stroke?
Yes, for the stroke case.
I-
So your approach is always to start with, was that a Salamba technique or was it
Adapt technique.
the adapt technique?
First
And
of all,
you would always, that would be
yes,
your first
because
choice
it's
always?
faster, cheaper, etc., etc.
What caught my ear in the presentation is that you use thrombectomy in case of failed thrombolysis. How long do you wait until you discover that it's failed, or you wait at all?
Only 1 hour, nothing more, not more.
So 1 hour, you
Yes,
usually wait 1
it's
hour.
enough to understand that the IV it will not work.
So I know that you do it, but it wasn't in the video, which is the post-procedural blood pressure control and the post-procedural
Yes.
blood pressure management. So I think there, having an image routinely done after the procedure is finished to see whether there's any hyperdensity can sort of guide how aggressive you are with the blood pressure management and with any blood thinners afterwards. Question, do you routinely give antiplatelet therapy after the procedure?
It depends. Of course, first of all, we know that the control of the blood pressure is crucial for the treatment of stroke. For the double antiplatelet therapy, in regular, we start after the CT scan after the procedure. Yes, we do it. We use double antiplatelet therapy. Other questions from the audience? Okay.
So from the timing, so what do you aim for? How do you aim to be sort of from, you've done the imaging, how is your activation cascade? So you have the ambulance service?
Yes, ambulance comes with the patient. After that, we have a neurologist on the duty in the emergency room, and he is the guy who will manage the process with the intravenous thrombolysis, and if they don't have a result, they call the endovascular team. We use artificial intelligence, BEC, and all of the guys from the team has software, and we know that we will do the endovascular treatment of the patient.
Perfect. Thank you very much. Are there any questions otherwise from the audience? No?
And the second video is for the probably second largest issue for the stroke in the young patient. This is the dissecting pathology. And please, can you... one moment.
We have a second case?
Yes.
Perfect.
We have 3 cases.
Okay, wonderful. Yes, always when you have a young patient, your
Yes.
fear is, could this be a dissection underlying?
Most of them.
Yeah, very often you do not have a trauma, even in the history, even without one.
Most of the patients with dissecting pathology are below 15. It is very serious problem, and for this reason I prepare one video about the dissecting pathology in the...
Yes.
Yes, dissecting.
So from a dissection, if you have a dissection in one vertebral artery, the other vertebral artery is not hypoplastic and is patent, and you manage to get the thrombus out of the basilar, for example, would you still go and treat the other side, or would you?
It depends, yes.
Yeah,
it's
yeah.
wonderful question
It's a-
to treat or not to treat, to stand. Yes, it depends about the clinical condition of the patient, of course.
Yes.
We don't cure the images of on the screen. We treat the patient, and for this reason, sometimes I stop only with a thumb aspiration and nothing more. But in part of them, it's need after the PTA to stand, and this is the main question, to stand or just to stay with PTA.
And the resulting disability. The patient woke up at 6 a.m. feeling well. During his morning routine, he started complaining of a headache, and by 6:30 a.m., his relatives noticed facial asymmetry on the left side, speech impairment, and limited movement in his left limbs. An emergency medical team transported him to the emergency department at St. Anna University Hospital, where his blood pressure was measured at 180/90. After conducting paraclinical examinations, a decision was made to proceed with endovascular treatment. 1 hour and 45 minutes after the onset of symptoms, the patient was already on the operating table. NHSS, 23 points. Severe left-sided central hemiparesis, progressing to plegia. Left-sided central facial glossoparesis. Rightward horizontal gaze palsy. Left-sided hemihyposthesia. The reason for opting for endovascular intervention was the patient's age and a NHSS score of 23 points, which raised suspicions of dissection or the occlusion of a large blood vessel. A CT angiography revealed that the dissection extended from the extracranial to the intracranial petrous segment. Procedure. We began with an 8 French guiding sheet and an 8 French guiding catheter. Using a 0.035 guide wire, we navigated through the true lumen of the dissection and placed a 6 French distal access catheter beyond the dissection site. Next, balloon dilation was performed using a 4 by 20 millimeter balloon at the dissection site, aiming to reposition the intimal flap in the intramural hematoma zone and restore the vessel lumen. We achieved successful recanalization. At this critical moment, preserving access to the true lumen was essential. We repositioned the distal access catheter, advanced through the true lumen, and placed it in the siphon of the right carotid artery. But the control angiography revealed reocclusion of the carotid artery. We used a Scepter 4 by 20 millimeter balloon for an intramodeling technique. Due to its sensitivity, we avoided using a manometer and inflated it manually with a 3 milliliter syringe. We made several attempts with balloon dilations in the dissection area, but the effect was short-lived, which led to the decision to place a stent. As the lumen did not open sufficiently, the patient was placed on double antiplatelet therapy, and a bolus of GP2B3A inhibitor, tyrofovir, was administered, followed by a 24-hour infusion. Here we can see the insertion of another balloon dilation. To optimize the result, we perform post-dilation. After multiple attempts, we switched to dilation using a non-compliant 3x20mm balloon with manometric inflation. Due to complex vascular anatomy, advancing with a standard cardiology balloon was challenging. Instead, we used a 4x15mm balloon Here we can see the final result after post-dilation. We can see the imaging and clinical outcome. A follow-up CT scan is performed for further evaluation. Here we can see the patient after discharge. Thank you for watching.
Thank you.
We would like to present one of the most common causes of ischemic stroke in patients under 45 years old and the result.
It's very difficult to merge 3 hours procedure to 10 minutes video. Sorry about that. I don't know. I don't remember. Yes, probably Enterprise. Yes.
My question would be: in the video, you said they said that actually you used tirofiban and you gave pills to the patient. Do you have intravenous aspirin available?
No,
in
I don't
Bulgaria?
have it on the shelf, unfortunately.
Because I mean, that's also a good thing that it's not expensive. It's difficult
Yes.
to get it.
Yes.
Finally, we had a big shortage, and we finally ended up buying it in Belgium. But now we have it.
I fully agree, but I don't have on the shelf intravenous.
We have to do the same. We're also getting our aspirin. We're getting it from France or from the Netherlands. So
Yes.
IV aspirin. The one thing with the clopidogrel, so the clopidogrel, if the patient can swallow, I mean, that's great.
I don't use clopidogrel
Oh, okay.
less than 2 years. I use
Yes.
prasugrel directly.
Prasugrel.
Yes, it's better. It's safety, especially for the young patient.
Yes.
If it's elder, after that I will a little bit considered using
The only
clopidogrel.
problem with prasugrel is a legal problem. It's currently on the FDA label, stroke is a contraindication to it. It doesn't mean that it's not
Same as
working.
the other, yeah.
It's just because when they run the study, the TIMI-38, in acute MI, they had an increase in hemorrhages in the post-stroke population, and it is still on the label. So even though it is working and many neuro people are using it, you have to know that if there will be a problem, it will be difficult to defend. If you're using ticagrelor, on the other hand, which is also available and it's quite similar, it is allowed in stroke.
Yeah, I agree, but we don't have testing in hospital for the resistance of clopidogrel. For this reason, I don't want to risk.
I know. I mean, the use of the medication is completely reasonable.
Yes.
The problem is this label, what they have actually, and the potential legal consequences.
Yeah.
It's not that it wouldn't work. It's just that's how it is. I don't think if you compare, ticagrelor is allowed, but I don't think ticagrelor would be any safer compared to prasugrel. It has never been compared.
Yeah.
It's just two different studies, and their conclusion ended up in having this label basically for the permission.
And you are right not to use clopidogrel in the acute phase, because clopidogrel would take about 3 hours because before it has any effect in the body if you give it as the tablet form. So yes. You're right there. Perfect. And another case.
Yes, it is first patient of first Artis device in Bulgaria. It was yesterday. It is pre-recorded case. Actually, this case was planned for today, but for the technical reason we do the pre-recorded. And please.
Welcome to this presentation on the Artis trademark intrasaccular device. Treatment challenges for bifurcation. Aneurysms. Bifurcation aneurysms present significant treatment challenges. Traditional approaches like surgical clipping, coiling, and stent-assisted coiling have limitations. Factors such as patient tolerance, the need for dual antiplatelet therapy, coil compaction, and difficult anatomy make treatment complex. Intrasaccular devices provide a promising alternative, addressing gaps left by these methods. About the Artis device, the Artis intrasaccular device is a self-expanding closed-cell flow diverter. It sits entirely within the aneurysm, eliminating the need for long-term dual antiplatelet therapy. Designed with a flared shape, it ensures a stable implant fit in wide-neck aneurysms. The device is compatible with a 0.02 1-inch microcatheter, with rebar 18 recommended for optimal performance. Key device attributes. Artis is constructed from braided nitinol and platinum-drawn filled tube wires, enhancing visualization during deployment. A distal marker band aids in precise placement while maintaining an atraumatic tip. Gradual opening allows controlled and safe placement. Fluorosafe markers minimize radiation exposure by indicating when fluoroscopy should be used. Artis detachment device. Indications, MRI compatibility, and contraindications. The Artis intrasaccular device is intended for the endovascular embolization of saccular intracranial aneurysms. It is MR conditional, allowing safe MRI scans immediately after placement under specified conditions. The device is contraindicated for patients with active bacterial infections. In non-clinical testing, the device caused minimal imaging artifacts, extending approximately 2 millimeters from the implant. Aneurysm selection recommendations. Artis is ideal for treating wide-neck bifurcation aneurysms located in the basilar apex, internal carotid artery terminus, middle cerebral artery, and anterior communicating artery. It is recommended for unruptured aneurysms and should not be used if multiple aneurysms are treated in the same procedure. On January 18th, a 51-year-old female patient was transported to the emergency department of St. Anna Hospital with acute right temporal headache. A CT scan revealed a saccular aneurysm of the right middle cerebral artery. Measuring 12 by 8 millimeters with a 4 millimeter neck, as well as a left MCA aneurysm measuring 7 by 6 millimeters with a 3 millimeter neck. Subarachnoid hemorrhage was observed along the falx, ambient and interpeduncular cisterns. Following an angiography, it was determined that the most likely source of bleeding was the right MCA aneurysm. The aneurysm was successfully excluded from cerebral circulation through simple coiling technique. 2 months later, the left MCA aneurysm was assessed as high risk for rupture. The patient was hospitalized, and after a contrast-enhanced CT scan, a decision was made to proceed with endovascular treatment using the Artis intrasaccular device. Here, we can see the preparation of the operating table and the flushing of the catheters before the procedure. Here, we can see the puncture of the right common femoral artery using the Seldinger technique and the placement of an 8 French guiding sheath. Next, 5,000 units of heparin are administered. A 3D control angiography is then performed to assess the condition of the coiled aneurysm. The aneurysm is successfully excluded from cerebral circulation, achieving a Raymond-Roy occlusion grade 1. We proceed with a control angiography of the left side. Here, we can observe the 3D reconstruction data, revealing a wide neck aneurysm. A diagnostic catheter is exchanged over a 0.35-inch guide wire for an 8 French guiding catheter, followed by the placement of a 6 French distal access catheter. The guiding catheter is advanced into the common carotid artery, while the distal catheter reaches the siphon of the left carotid artery. Next, we place a rebar 18 microcatheter. Here, we can see the flushing of the microcatheter and the reshaping of the microwire in preparation for navigation. Using a roadmap technique, the catheter is positioned. We then advance the distal catheter and microcatheter to the target site. Deploying the device, Position the microcatheter so its tip sits within the aneurysm sac, ideally between 1/3 and 1/2 of the aneurysm height. The catheter should remain away from the aneurysm dome. In shallow aneurysms, operators may deploy closer to the aneurysm neck for better control. Using SIM and size for sizing helps simulate the placement, wall apposition, and compression of different implant sizes to determine the best fit. This tool simplifies the selection process, using angiographic measurements to recommend the most suitable implant. SIM and size simulation process. By inputting aneurysm measurements, SIM and size software simulates the appropriate Artis implant size. This technology aids in visualizing device positioning and optimizing treatment decisions. Sizing the device. To ensure proper selection, measure the aneurysm in the anterior, posterior, and lateral planes. The sizing chart provides recommendations based on aneurysm dimensions, accounting for slight oversizing. The final size may vary depending on aneurysm shape. Sizing example: for accurate device selection, measure aneurysm width, height, and neck size in 2 projections. If the aneurysm width is between recommended sizes, a larger device may be selected while considering aneurysm height. For example, an aneurysm with an average width of 4.8 mm and height of 7.5 mm would require an Artis 6.5 by 5.0 implant. After multiple calculations, we decide to use an Artis 7.5 by 4 device. Prepping the device, examination and degassing. Inspect the device for any visible damage. Sheath the implant by pulling the wire slowly. Next, degar the device by placing it in a sterile, heparinized saline bath. Deploy and resheath the device multiple times while submerged, ensuring all air bubbles are removed. Insert the sheath into the Y connector, positioning the tip just before the junction. Tighten the hemostatic valve and backflush to check for saline drops. Open the valve, seat the sheath inside the microcatheter hub, and tighten the valve before advancing the implant. Fluorosafe indication. The Artis delivery wire includes fluorosafe markers that help reduce radiation exposure. These markers indicate when fluoroscopy should be used, ensuring controlled deployment while minimizing unnecessary imaging. Deploying the device, distal marker alignment fluoroscopy should be used to ensure the distal marker sits correctly within the Artis basket. The marker is slightly offset from the distal tip to maintain an atraumatic dome and aid in follow-up imaging. Deploying the device, controlled delivery. Slowly push the pusher wire while retracting the catheter to allow Artis to flower. Once 1/3 deployed, the device becomes soft and conforms to the aneurysm wall. The Artis detachment device is a handheld, battery-operated system designed for precise detachment of the Artis implant. It features a cathode wire clip, anode wire clip, patient connecting cables, detachment indicator, push button, and battery status indicator. Detachment process. Attaching the ADD. To prepare for detachment, wipe the proximal end of the wire with alcohol. Connect the grounding wire to the patient's shoulder using a sterile needle and attach the anode clip to the pusher wire. And hold the power button for 3 seconds to turn on the device. The LED indicator will confirm readiness when the battery light turns green. Initiating detachment. To start detachment, press the button for less than 3 seconds. The LED will glow blue, and the process will complete in approximately 60 seconds. Confirming detachment. Once detachment is successful, fluoroscopy should be used to verify implant separation. After confirmation, remove the anode clip and grounding needle before turning off the device. The procedure is completed with a final 3D angiography, verifying the position of the Artis device and vessel patency. On the follow-up MRI with contrast, a complete occlusion of the treated aneurysm was confirmed. And finally, we present the patient 24 hours after the intervention. Thank you for watching.
Thank you.
Thank you, Nuri. Nice presentation. Thank you. Since Artis is the latest version of intrasaccular devices that are already available on the market, I wonder if you have a comparison to previous ones regarding performance, ease of use, etc., etc. Did you use other intrasaccular devices before?
I use web.
Okay, so what is your feeling?
Probably in my mind, the biggest challenges is sizing of the device, because to have a Siemens cure, it will cost lots of, probably, I don't know. But since for the deployment, I don't find that any difference between the web and Artis. I don't know. It was easy to put. It was, for me, it was for the first time. I don't know. It's same, but in my mind, it was difficult to find precise size for the implant.
Was it any different from web?
Yes. With Siemens size, I don't know, the sizing, it was difficult. We measure half hour simulation, and in the end, we decide, okay, we will put this device.
So this would have been my next question, how much the Siemens size helps you? I mean, is it easy, or you repeat again and again and again,
Yes.
and you try this and try
Yes,
that, and
yes,
then
yes,
finally
yes.
you say,
40 minutes probably.
Let's do that.
Yes, yes. There is a lady from Hungary. She supports
Yes,
us for you know, he probably.
yeah, I know.
Yes. And it took 40 minutes to decide the size of the device.
Right, that's absolutely true. Anybody from the audience has experience with either this device or
It was
other?
first time in Bulgaria.
Okay, so probably not nobody. We actually experienced one performance difference, which I believe is important, and I did see that a little bit happening in your case as well, but Sándor is probably better to tell our very first experience, which was in his hands.
So basically, it is a very soft device, and whenever you have little daughter sucks, those daughter sucks can actually suck up some of the device itself. And what happened in our case is basically after we have detached the device, it retracted because it went into those daughter sacs. So when you're treating complex morphologies with the Artis, you need to be very. This was a very ideal aneurysm for the treatment, very ideal form. But once you have a more complex form with daughter sacs, you have to be very careful because it might not behave how you would have anticipated. This is what happened for us. So in the end, some part of it actually got invaginated in one of the daughter sacs, and basically it retracted partially from the neck. This is something that would not happen with a more strong radial force device. So that it's something that we need to learn as well. I mean, thanks to Istvan, we have a large experience with them, participating in the lab studies for a long time. But this is also a learning for us with the Artis to learn that it is a nice device. It can be used with the appropriate form aneurysms, but you have to be careful because of this very soft structure.
Thank you.